انه لازم نبقى عارفين انه الامتحان ده وسيله ما هوش غايه. ان شاء الله كلكم هتجيبوا درجات كويسه، الامتحان هيبقى في متناول الجميع باذن الله تعالى. بس اللي احنا عايزين نبقى دكاتره كويسين. الجزء بتاع الفاسكولار سيرجري متداخل في اشياء كتير قوي. ان شاء الله لما تتخرجوا وتشتغلوا، في منكم اللي هيشتغل الشغلانه دي وفي منكم اللي هيشتغل حاجه ثانيه. عموما المعلومات اللي هتاخدوها في الفاسكولار سيرجري هتنفعكم سواء انتوا اشتغلتوا حاجه فيها جراحه او اشتغلتوا حتى الاشياء اللي هي الباطنيه. هنبتدي النهارده بحاجات خفيفه. احنا عندنا الفاريكوز فينز، هنبتدي بيها. دي انا بتمنى لكم يعني ان شاء الله ان ربنا يوفقكم باذن الله تعالى لغايه ما الغمه دي تزول ونلتقي على خير باذن الله تعالى. الفاريكوز فينز لازم نعرفها كويس، حاجه من الحاجات المشهوره كتير واللي بنتعرض لها كتير قوي في حياتنا. By definition, varicose veins عبارة عن dilated, elongated, tortuous veins. This dilatation as a result of increased pressure. يبقى إذا the cornerstone for that is the presence of increased pressure، زي ما احنا هنشوف ازاي حصل الكلام ده. عشان نفهم هذا الكلام لازم الأول نعرف إنه اللور limb veins مما تتكون. في عندنا deep veins وفي عندنا superficial veins. The reference in that is the deep fascia. Veins which are deep to the deep fascia are called the deep veins, and veins which are above or superficial to the superficial fascia are called the superficial veins. They are communicating to each other by what's called the perforator veins, and they are called perforator veins because they pierce or they perforate the deep fascia, and they convey the blood from the superficial system to the deep system, and this passage is guaranteed in that direction by the presence of unidirectional valve. These valves allow the passage of the blood from the superficial veins and prevent its return to from the deep veins to the superficial veins. Superficial veins, we have two big sets of veins which are the great saphenous vein، وده باللغة العربية بيسموه الوريد الصافيني، وسمي صافيني لأنه هو جاية من الصفاء، إن هو هذا الفين بيبقى ظاهر واضح. It is the longest vein in the human body. It starts as medial continuation of medial end of the dorsal venous arch of the foot, and it ascends in front of the medial malleolus on the anteromedial aspect of the leg till it reaches the knee. Then it goes upwards on the medial aspect of the knee and on the anteromedial aspect of the thigh, and it ends by joining the common femoral vein at the saphenofemoral junction, which is situated 4 centimeters below and lateral to the pubic tubercle, and this site is protected by a valve which allows the passage of the blood from the great saphenous vein to the common femoral vein, and it prevents the passage in the opposite direction. Short saphenous vein, this is the short saphenous vein, and it starts as the lateral continuation of the dorsal venous arch of the foot, since behind the medial malleolus, dead posterior in the leg until it reaches the popliteal fossa, where it ends in the popliteal vein, and this site of communication is called the sapheno-popliteal junction, and also it is guarded by that allows the passage of the blood from the short saphenous vein to the popliteal vein, and it prevents the passage of called the communicating veins, and they have different names according to their situation and according to their location. This is beyond our scope. So therefore we have the great saphenous system and the short saphenous system, and there are communicating veins in between, as we have elucidated to you. The deep veins accompany the artery, and they granted their names according to the name of the arteries. Therefore, here we have a posterior tibial vein, anterior tibial vein, and peroneal veins, which could be single or they could be multiple veins. and they convene or converge to each other and forms the popliteal vein. This popliteal vein becomes the superficial femoral vein. The superficial femoral vein joins the deep femoral vein, and they form what's called the common femoral vein. The deep veins contains valves, as you see. This is bicuspid valves. These bicuspid valves allow the passage of the blood from below upwards, and if the blood returns from upward downward, this valve will close and prevent its passage in the opposite direction. This is the anatomy of the perforator veins. If this is the deep fascia, and you have the deep veins and you have the superficial veins, these are the perforator veins, which are processing valves that allow the passage of the blood from the superficial system to the deep system and prevent the passage of the blood in the opposite direction. Venous return from the lower limb is against nature because it is against the gravity, and if you stand on your foot, you can imagine that the column of the blood is the weight of the column of the blood is or equals the weight from the foot to the right atrium. Therefore, it is an active process. It is not a passive process as we once thought. There must be an active pump in the lower limb to propel this blood against this gravity to reach their destination and for the circulations to continue. We have different factors. The most important is the muscle pump, which is called the peripheral heart. Other factors which are contributing to a lesser extent to the passage of the blood or the venous return are the pressure gradients between thoracic abdominal cavity and the lower limbs, where the pressure, as we know, in the thorax is a negative pressure and in the lower limbs is a positive pressure. This pressure gradient is in favor of the passage of the blood from the lower limb upwards to the thorax. Also, transmission of arterial pulsation onto the venous wall, because they are closely applied to each other. If you find the vein, you will find the artery very close to it, sometimes enclosed in the same fascia together, and these arterial pulsations serves as a propellant to press on the wall of the vein, propelling this contained blood upwards to the heart. Most important is the muscle pump, and this is called the peripheral heart. What do you mean by the muscle pump? This muscle pump is in the calf muscles. These calf muscles surrounding the deep veins, and all are enclosed in the deep fascia. How does it work? During relaxation of these muscles, blood will stagnate inside of the veins. When this muscle contracts, it will propel the blood upwards, and the presence of these valves along the communicator veins will prevent the passage of the blood from the deep system to the superficial system. When the cycle of contraction is repeated, the blood relaxation of the muscle from the superficial into the deep system, and the process is repeated. As you see, this is during muscle contraction and this is during muscle relaxation. The integrity of this peripheral heart or the calf muscle pump depends upon the integrity of the muscles. Therefore, if the patient cannot contract his muscle, this pump will be deficient, and also the deep fascia is important, and competent veins, competent valves are very important. These three components are very important. If one component is affected, the function of this calf muscle pump will be affected proportionately. Varicose veins, as I say in my introduction, these varicose veins are caused by derangement of pressure. There is an increased pressure inside of the vein. This increase of the pressure will lead to accumulation of the blood inside of the vein, and therefore the vein will be dilated, elongated, and tortuous. How it could happen? This could be the result of a primary cause or secondary cause. The primary cause could be there are a number of the valves present. Sometimes this number is below the average. Therefore, there is an increased pressure applied over particular parts or a particular segment of the vein. This will respond by dilatation, elongation, and formation of varicose veins. This is number one, the deposity of the valve. Valves are decreased in number than usual, or the valves are congenitally incompetent valves, or there is a weakness of the vein wall. It cannot withstand the normal pressure to which it is subjected. Therefore, it is dilated, elongated, elongated, and tortuous. This happens in case of the weakness of the mesenchyme. For that, we have think of other things if we are examining patient who is complaining of flat foot and presence of hernia as well, because they could be other representation of this weakness of the. Also, pregnancy is a multifactorial cause for the development of these varicose veins. It can be a mechanical cause by the compression of the growing uterus as the pregnancy goes forward, and also due to the relaxing effect of the pregnancy hormones, which are produced at a tremendous, huge amount during pregnancy, as you know. Hormonal contraception or contraceptive pills works the same way, the hormonal effect during pregnancy by relaxing effect over the veins, and also the hormonal replacement which is used to control patients of menopause. Secondly, varicose veins are mechanical causes for that. This is maybe previous DVT or presence of pelvic tumor or presence of arteriovenous fistula. In case of the DVT, DVT happens and it ultimately will be cured or improved. The vein is getting at first occluded, but after that there will be natural thrombolysis will happen and recanalization of the previously thrombosed vein will happen. But this on the expense of the function of the valves. The valves will be permanently destroyed, and therefore there will be an effect of that destruction of the valves, and ultimately the patient can develop secondary varicose veins. Pelvic tumor, the compression of the venous return from the lower limb increases the pressure, elongation, and tortuosity to accommodate this increased amount of the blood inside of the veins. Arterial pressure is transmitted to the venous side, which is not used to bear such high pressure, so they will be congenital arteriovenous fistula, or trauma can lead to communication, abnormal communication between the artery and the vein, and arteriovenous fistula will develop. Other the presentation, sometimes the patient is coming complaining of heaviness and discomfort, usually towards the end of the day. Edema of the foot and the ankle, again, usually is towards the end of the day. Sometimes there is a pain along the affected vein due to the overstretch of that vein will stimulate the nerve endings and produce pain. One of the most common presentation is aesthetic concern. Cosmetic concern the patients come because of produced. Complications can develop from these varicose veins in the form of ulceration, pigmentation, or dermatitis.
دكتور
presentation of ايوه اتفضل.
aesthetic concern بس لأن الصوت قطع فما سمعتهاش.
Aesthetic concern, cosmetic effect, disfigurement that these veins produces to the patient. This is a common presentation because these varicose veins, as we said, these varicose veins much more common in females than in males who are concerned about their appearance. Also, the patient can present by ulceration or pigmentation or dermatolyte or sclerosis, but these complications can, or this presentation can complicate long-standing varicose veins rather than the primary presentations of that veins. Clinical examination has been supplanted by the duplex examination. What I mean by supplant have been replaced and exceeded by the duplex examination because they are all subjected to the human errors, and we teach them as of the academic interest. But the same things we need to know from the duplex examination. Back to the clinical examination, saphenofemoral, we should seek three things. If the saphenofemoral junction is incompetent or competent, this is number one. Number two, if the great saphenous vein itself is incompetent. We mean by great saphenous vein incompetent or not by the valves inside of this great saphenous vein, whether they are competent or not. And lastly is the incompetent perforator, whether there are incompetent perforators or not. For the saphenofemoral junction incompetence, we can seek them on clinical examination by performing Trendelenburg's test or by thrill on coughing at the saphenofemoral junction. An incompetent great saphenous vein is determined by applying the Schwartz test, and the incompetent perforators, we have these all types of the test. Number one is Fagan's test, number two is the two fingers test, and lastly is the multiple tourniquet test. During the clinical course, we will elucidate how they could be performed. But again, they are subjected to human error. Been the duplex examination, but the duplex never should comment on these three. What about the saphenofemoral junction? What about the incompetent saphenous vein? And it can give a measurement for the diameter of the great saphenous vein, and also the site and the status of incompetent of the perforators, whether they are competent or not. During clinical examination, in addition to that, we have to seek for if there are groin lymph nodes, if there is an ankle ulcer, and we should examine this ulcer, should describe it as you will learn it in general surgery, to seek if there is an edema of the lower leg. Usually it is in the varicose veins, it would be around the ankle. There's complications of these varicose veins in the form of thrombophlebitis of these varicose veins could be seen as redness and tenderness. We should see if there is dermatolyte or sclerosis. We should check for the pedal pulses of the patient or the presence of the arteriovenous fistula. How we can reach this arteriovenous fistula? There is thread over the vein by the patient, and if you put a stethoscope over this vein, you will hear what's called machinery murmur. You will this continuous murmur, which will end the diastole. This is called machinery murmur. Also, we should examine the patient for the integrity of the calf muscle. How is range of movement of his ankle, whether it is free, it is not. This has its implications on the calf muscle, if there is a weakness of this calf muscle or not. Evaluation of the patient with varicose veins should go as follows. We should have a history taking, we should apply clinical examination, and we can plethysmography and duplex ultrasound. The commonly used is the duplex ultrasound, but we should know that there is another form of investigations for this, which is called treatment options. To treat this varicose veins, the treatment should be tailored for each patient. What I mean by tailored for each patient. Sometimes this patient is given one single line of treatment or a combination of lines of treatments according to the situation of that patient. What are the available options present? We have number one, compression, which is called the Hussein or the compression therapy, or the elastic stocking, which could be knee length, commonly called the elastic compression elastic stocking, or waist length, which is commonly termed above the knee graduated elastic stocking. You can apply pressure according to the class from 20 to 40 millimeter mercury. This is class 2, or even above this from 40 to 50. This is class 3. This class 3 is reserved for the severe cases, complicated cases of varicose veins, or in case of the lymphedema. But the commonly used type is the class 2, which exerts pressure ranging from 30 to 40 millimeter mercury. We have another option for that is the injection sclerotherapy, and we have a surgical intervention. This surgical intervention could be or without saphenous vein extraction. This is one of the surgical options. If by could be at time by
دكتور
عايز تقول
صوت هو الدكتور الصوت قطع خالص
اول فين؟
من اول surgical intervention.
حاضر هعيدها حاضر. Surgical intervention which could be by open surgery in the form of femoral disconnection with or without saphenous vein stripping. هنشوفها بعد كده. This is could be also supported by phlebectomy, is to remove these untoward small communications when they are ugly and troublesome to the patient. We have the other thing is the saphenous vein ablation. This is could be by radiofrequency ablation or by the laser ablation or by to know that we have these options. You should know their names and small idea about the principles. Very few information you need to recall about this. This is how the injection sclerotherapy is being performed. This is the affected vein, and this vein needs to be injected by sclerotherapy. The idea of this sclerotherapy is that what is the idea of the sclerotherapy? The idea of the sclerotherapy is the vein is visible because it contains blood, and what you see on the surface is a reflection of the color of the blood over the wall of the vein. Therefore, these veins could appear usually green in color or bluish in color. Or hue between both greenish blue in color. If these veins are no longer conveying blood, they will disappear. Their effect will disappear, will be concealed. But the sclerotherapy, by injecting this sclerotherapy inside of the vein, the wall of the vein will adhere to each other, and the vein will be permanently collapsed and no longer convey blood through it. Therefore, it will be invisible to the onlooker. This is the principle of the injection sclerotherapy. This injection sclerotherapy by varieties of sclerosing material could be used. Sometimes we change it into foam and produce what's called the sclerofoam sclerotherapy. سامعيني حاجة قطعت؟
لا تمام يا دكتور.
تمام يا دكتور.
سامعين حضرتك.
طيب تمام. This is a very simple technique, can be performed as an office job. It needs theater. You introduce this is butterfly side to inject sclerosing. Ultimately, the wall of the vein will get adhered to each other. No blood visible immediately. Surgical intervention, saphenofemoral disconnection with or without saphenous. We perform an opening the inguinal crease. Will be totally hidden. The scar of which will be very acceptable by most of the patient. We dissect until we reach the saphenofemoral junction. There are three notorious tributaries here. We ligate them all, and we ligate this saphenous vein flush with the common femoral vein. Stripper is introduced inside of the vein through another incision made about the knee, and thereafter this vein is stripped and like this way. الفين ستريبر ده عامل زي السلكه بتاعت العجله، فرامل العجله او سلكه الدبرياج. في اخرها بيبقى فيه نوب كده موجوده، فلما بندخل السلكه دي وتطلع من طرف الفين من الناحيه الثانيه نربط النوب دي، بعد كده نشد الفين كله يبقى افالسد معانا ويطلع معانا. دي بيسموها فين stripping or stripping grade. We can perform femoral disconnection with or without saphenous vein according to the situation. If this vein is very ugly, we remove it. If the vein is acceptable and not ugly, for involution. What I mean by involution? Involution, you removed the effect of the incompetent saphenofemoral valve. Therefore, this vein will be no longer subjected to higher pressure coming to it through this incompetent saphenofemoral junction valve. This vein will, upon time, will involute like the uterus after birth will involute. But there is no way for the involution to make it back to its original size. Or in that situation, we are obliged to strip this vein. This is also could be supported by phlebectomy. Here, this is how the phlebectomy is performed. Stab incision. This is 2 or maximally 3 millimeter incision is performed. Hook is introduced. The vein is hooked and it is pulled out through this incision, and then the incision is stitched usually with single stitch. Here is the ablation. This is in that you can perform an ablation of the great saphenous vein. As I have said before, you can use the radio frequency ablation, you can use the laser ablation, or you can use mechanical ablation. In the example I'm presenting to you is the laser. This is the knee joint of the patient. We put what's called sheath. This is axis sheath. Axis sheath will be explained and discussed with you during the endovascular session, which we schedule later on. This is sheath. This is called axis sheath. Axis sheath because it permits you to have an access to the vessel you are dealing with. Through this sheath, It's introduced into the vein. The sheath is protect the passage of the blood from inside of the vein to outside to prevent bleeding from and through this catheter with laser at its tip is introduced until it reaches just below the saphenofemoral junction. Firing of this laser source will destroy the intima of the vein, and ultimately this vein will collapse and will adhere to each other. And we do it as we withdraw this catheter outside until the whole segment is treated. It gives the same results as the ligation of the saphenofemoral junction and the strapping of the saphenofemoral junction without the need for post-operative compression to prevent ecchymosis, because the Trendelenburg operation of the saphenous vein notoriously produce ecchymosis in the side, which could be troublesome to the patient. These class of techniques are called minimally invasive because there is no much invasion, and because it is not medicinal products you are giving to the patient. It possesses some form of invasion, but this is minimal invasion, so they are called minimally invasive intervention or minimally invasive surgery. This is the end of this varicose veins, and I have to go to discuss with you the superficial thrombo. Give me a few seconds until I upload the other lecture. Are you with me؟ سامعني؟
يا دكتور احنا هنا.
طيب تمام، شايفين السكرين بتاعتي ولا لأ؟
شايفينها.
طيب هنتكلم دلوقتي على
بعد إذنك يا دكتور،
السوبرفيشال. اتفضل.
هو إيه الفرق بين الكوميونيكيتور فين والبورفريتور فين؟
this is misnomer. من زمان حصل فيه لخبطة، فعلشان كده خلاص اتقال انه الكوميونيكيتنج فينز دي دول الفين which are situated superficial to the superficial fascia، يعني therefore they belong to the superficial veins. They are called communicating because they communicate the two system to each other, great saphenous vein system and the short saphenous vein system. Perforators are entity or set of the veins which perforate the deep fascia. They are called perforators. They convey blood from the superficial system to the deep system, and they possess valves prevent passage of the blood in the opposite direction from the deep system to the superficial system. مش بقى الامور يبقى communicating دول belong to the superficial veins, and the perforators they pierce the deep fascia. Clear?
تمام يا دكتور، تمام.
طيب superficial thrombophlebitis. Superficial thrombophlebitis is the thrombosis of the superficial veins. Thrombosis of the superficial veins. We have for these superficial veins to get thrombosed, we have no definite cause, but there are some risk factors that could put the patient at risk of development of these varicose veins, of this thrombophlebitis, sorry. Most commonly, they occur in the varicose vein because the varicose veins are giving much of the environment for this thrombosis to happen. Namely, there is stasis inside of these veins, and this stasis is responsible for the development of these thrombosis inside. Frequently occurs as a complication of indwelling catheter. If you have a cannula inside of the vein, this cannula will produce sort of intimal injury inside of this vein, together with stagnation of the flow inside of the vein and stasis. All of them will lead to developments of this superficial thrombophlebitis. About 38 occurs in the upper limb. As much as 85% vein, because the cephalic vein is one of the sites of predilections for the insertions of this cannula in site. We call this, but you it is if it complicates indwelling catheter, it occurs in the upper limb much more than elsewhere. And if it occurs in the upper limb, 85% inflect the cephalic vein. This is to show the magnitude of the problem only, not to recall these numbers. Other secondary risk factors like the obesity, pregnancy, malignancy, prolonged recumbency, and hormonal therapy all will lead to affection and put the patient at risk for the development of these superficial thrombophlebitis. We have a special entity we should know, we should put in your mind, which is called the migratory thrombophlebitis. This is Trousseau syndrome. Migratory thrombophlebitis, it happens at a site and then it goes to another site, and over the course of a few months, more than 2 or 3 times. What's its importance? As we will discuss about the DVT, we should know that the patients who are suffering malignancy are at risk of development of the thrombosis anywhere, including the superficial system. But migratory thrombophlebitis, or the Trousseau syndrome, it is given special glory for this syndrome. See the diagnosis of carcinoma by Sapheno. Which kind of carcinoma? Usually of the pancreas and of the GIT carcinoma can be the presentation by migratory thrombophlebitis. Also, Behçet's disease or Berger's disease and polyarthritis nodosa, they are autoimmune diseases affecting the vessels in such a way that the body is attacking its own vessel. The ultimate result of this battle will be thrombophlebitis of the superficial veins. Disease, Berger's disease, and polyarthritis could be hallmark of hypercoagulative state. What we mean by hypercoagulative state? Sometimes there is congenital or congenital hypercoagulative state in which there is state of a tendency to reduce thrombosis more than more. The sole presentation of the patient in such conditions could be superficial thrombophlebitis.
دكتور
اتفضل.
الفاريكوز فين بيعمل ثرومبوفليبايتس بنفس، يعني بيعمل انتمال انجري برضو زي الكاثيتر كده، ولا بتكون ازاي الميكانيزم؟
The chief mechanism is the stasis inside, because there is accumulation of blood, stagnant blood inside. There will be an interaction between the coagulation factors present and the intima inside. but there should not be an intimal injury as it happens with the indwelling catheters. The exact incidence and prevalence of this thrombophlebitis cannot be adequately assessed. But its incidence increases as the age advances in both women and men. Its incidence in the lower extremity, this is a known things about it. The exact incidence, again, is not known, and its prevalence is not known. But there may be some reports pointing to that the overall incidence in the lower extremity is from 3 to 11%. We should distinguish between the superficial thrombophlebitis, which occurs in the varicose veins, and those which are otherwise in the normal veins. Why we should discriminate between them? There is an obvious cause for the development of the superficial thrombophlebitis in case of the varicose veins. But if there is no obvious cause in the normal veins, no indwelling catheter, no varicose veins, what should be? This could be malignancy, this could be hypercoagulable states, could be autoimmune disease like the Behçet's, Berger's, or polyarthritis nodosa. I should think of it not as a simple conditions, but I have to explain why did it happen. Exactly what happens is following what's called the Varicose triad. For the thrombosis to happen, we have to have endothelial injury, stasis, and hypercoagulable states. They may work individually or in combination to each other, and as more than one factor are involved, the risk for the development of the thrombosis is getting increased. Again, endothelial injury can lead to thrombosis, stasis can lead to thrombosis, hypercoagulable states can lead to this thrombosis. This is the Varicose triad, to remember it, in the form of a triangle. We have the endothelial injury, hypercoagulable state, and venous stasis. They work alone or in combination to each other. What are the examples of this endothelial injury? We have trauma. This could happen if the patient receiving a kick in the lower limb during football match. This can lead to formation of the thrombophlebitis, or putting an indwelling catheter inside of the vein, like in the upper limb cephalic vein. Stasis, the example of this stasis is the varicose veins, as we stated before. Hypercoagulable states, this could be congenital or acquired. The examples given here are congenital forms like the factor V laden, prothrombin G mutation, protein C, protein S, and antithrombin 3 deficiency, malignancy, thrombocytosis, and polythysemia. All of these examples are putting the patients at state of hypercoagulable state. Therefore, this patient is liable or at risk to develop superficial thrombophlebitis, and again, DVT also can be developed as a result of this, as we will see during discussions of the DVT. Details of them are not, or they are beyond your scope at all. You should know that there is a congenital hypercoagulable state, and you will be grateful if you know some terms of them. Other risk factors: obesity, pregnancy, prolonged recumbency, surgery, and hormonal and radiation therapy also can all lead to thrombophlebitis. Migratory thrombophlebitis, or to say syndrome, as we said before, can precede the diagnosis of carcinoma by several years, or complicate Behçet's, Berger's, and polyarthritis nodosa. Could be the hallmark of hypercoagulable states. What about this Mondor's disease? Mondor's disease, some of the clinical curiosity and site of place for oral exam question is Mondor's disease. Superficial thrombophlebitis of the superficial veins of the chest wall. Also, the term Mondor's disease is applied if the superficial dorsal vein of the penis is involved by superficial thrombophlebitis. This is termed Mondor's disease. They don't have a special attention except their name, which is given through history. This is Mondor's disease, and as we see, there is a thrombosis of one of the superficial veins in the chest wall, which appears like red and cold like structure, and if we palpate it, it will feel like a cord, and of course it is tender to palpation. Superficial thrombophlebitis has its importance or its risk from the involvement of the deep veins, because as we have given to you during the anatomy explanation of the anatomy of the veins of the lower limb, that these superficial veins will attach or convey their blood to the deep system. Therefore, they communicate with the deep system at different levels. It could extend the superficial thrombophlebitis, could start in the superficial vein and could spread or extend onto the deep system. Also, sometimes the thrombosis starts in the deep veins and leads to deep vein thrombosis, and as a sequel of this deep vein thrombosis, superficial veins get involved. So there is, we should view them, this patient is having at the same time DVT or not, because there is a risk of this present. And if this risk is overlooked, this may lead to a serious problem of pulmonary thromboembolism to that patient that could cost the patient his life. Clinical presentation, like inflammation anywhere. In addition, there is a cord-like structure which is tender to feel. This is painless, redness, hotness, along with the course of the affected vein. Although the clinical picture is obvious, but we should apply an ultrasound confirmation for our diagnosis and to exclude the involvement of the veins, which is very important for the fear of the development of pulmonary thromboembolism. So, although this clinical examination, clinical picture is obvious, we should offer the patient ultrasound confirmation, I mean duplex ultrasound, in order to exclude the presence of deep vein involvement. As you see, concomitant deep vein thrombosis of the lower limb occurs in 5% to 40% of cases of the superficial thrombophlebitis. If you see 100 patients with superficial thrombophlebitis in the lower limb, 5 to 40 of them have at the same time DVT. Therefore, we should offer this patient ultrasound, duplex ultrasound. This is of a particular attention. If you have, as we have said to you, the saphenous vein ends in the common femoral vein at the saphenofemoral junction post-centimeter lateral to the pubic tubercle. If this great saphenous vein get involved by superficial thrombophlebitis and it extends to reach the saphenofemoral junction, it may almost common femoral. This risk is increased according to the site where this superficial thrombophlebitis reaches. If it is within 1 centimeter below the saphenofemoral junction, the patient is at higher risk of extension into the common femoral vein and the DVT with the risk of pulmonary embolism. Treatment of the superficial thrombophlebitis, I should verify if this what was the cause for this superficial trauma. The patient received trauma. Patient has had indwelling catheter inside. The patient has varicose veins. This could explain what has happened. If I have no obvious explanation for that, I should reach the cause for that superficial thrombophlebitis. Therefore, the treatment should not focus on the treatment of the superficial thrombophlebitis alone, but should extend to include the cause for this superficial thrombophlebitis, because it is of great importance not to miss the presence of silent pathology in the patient. Treatment varies according to the severity and location. We have the severity and location will dictate what special treatment I should give to the patient. We have the low molecular weight. We have suitable compression plastic stocking, antibiotics, and rarely surgical excision of the involved vein. This is reserved for rare cases of septic thrombophlebitis, in which there is virulent fusion side of this vein, and it should be removed at that time. This is a rare encounter in the modern era of strong antibiotics. Superficial thrombophlebitis located more than 1 centimeter of the saphenous-femoral junction. I can give the patient anti-inflammatory prophylactic dose of low molecular heparin for 1 week. Some and I give the patient suitable. If it is within 1 centimeter of the saphenous-femoral, there is a debate about the surgical ligation or medical treatment. Both are equally effective. In the past, this was an indication for ligation of the saphenous ligation. The medical treatment both give the same results. Therefore, all of these patients should receive medical treatment, and there is no place for the surgical ligation nowadays. Conservative treatment should include anticoagulant ranging from 6 weeks to up to 3 months. Anticoagulant, suitable anticoagulant, usually oral anticoagulants. واحنا بعد كده هنشوف الاورال anticoagulants دول هم ايه وبناخدهم ازاي مع بعد كده هنبقى ناخد حاجات اكتر من كده. انا بس قلت نبتدي بحاجات خفيفه وما نطولش عليكم عشان ما تزهقوش. اللي عنده سؤال من فضلكم يقول لي دلوقتي.
دكتور
اتفضل.
السيرجيكال لايجيشن يعني دلوقتي حاليا بيتعمل الكونزرفاتيف، ما بيتعملش لايجيشن ولا ممكن يتعمل برضه؟
لا ما بيتعملش خلاص، لان هم زمان كان بيتعمل السيرجيكال لايجيشن for the fear of that thrombus to extend into the deep veins. But now they have found that ligation and medical treatment both give the same results. Therefore, why to ligate? طيب في برضه حاجه ثانيه، لو انت عملت له لايجيشن هتدي له انتي كواجولانت ولا لا؟ تدي له انتي كواجولانت، يعني اللايجيشن اللي انت عملته ده ما فادكش في حاجه. فهو عشان كده احنا لما بنلاقيه حتى extending up to within 1 centimeter of the saphenous-femoral junction بندي للعيان انتي كواجولانت. بس لو تاخد بالك الانتي كواجولانت ده هنديه ثيرابيوتيك انتي كواجولانت، ما هوش بروفيلاكتيك انتي كواجولانت، وهنديه extended period هتبقى من 6 weeks at least 6 weeks but up to 3 months. بس.
شكرا يا دكتور.
حد عايز يسأل على حاجة تاني؟ في أي سؤال؟ طيب نقدر نشوفكم بقى الأسبوع الجاي إن شاء الله فيس تو فيس، وأي هوب إن أنتم تكونوا استفدتوا من اللي أنا قلته.
شكرا يا دكتور.
شكرا يا دكتور.
العفو العفو. السلام عليكم ورحمة الله وبركاته.
وعليكم السلام.